Alright, so today we're going to be covering a total guide to recovering from a shoulder labrum injury. This is going to be a complete guide to help you recover from any sort of shoulder labrum injury without surgery, to help you get back into playing sports, lifting, or doing whatever it is that you enjoy doing. So first thing we need to consider was, number one, was there a clear mechanism of injury? This is going to be a big aspect of how we approach treating the area. So we need to determine, was there a clear mechanism of injury, or did this just kind of happen randomly without some sort of reason behind it? Is there hypermobility taking place in the client, or is there just a lot of stiffness in the shoulder? More common than not with labrum issues, you're going to find that there's hypermobility in these patients. This is definitely not a catch-all. There's some people with just normal range of motion measures, but hypermobility tends to be a little bit more common for injuring something such as the labrum. If we've had a mechanism of injury, such as laying out with the arm outstretched and landing on the shoulder, or getting a traction to the shoulder, those are the common mechanisms that oftentimes irritate the labrum. Or say a repetitiveness of an extreme range of motion, such as a task like pitching a baseball or throwing a baseball or throwing a football. These are things that cause labrum issues most commonly, but it could also be a different standpoint from a lifting, where someone's doing a ton of dips, a ton of push-ups, a ton of overhead press, or pull-ups. So these are all common things that you need to consider, but they are things that you can get back to doing without surgery. So depending on the circumstance, if there is a mechanism of injury, the general progression is going to be isometric contraction exercises, to then concentric and eccentric exercises, and then finally to impact or plyometric activities. And possibly we'll introduce some stretching based on their range of motion tendencies. If the person has any hypermobility tendency whatsoever, we should not be stretching this individual. If the person is in acute pain, we should not be stretching this individual. But there is a third subset of individuals, again, it's the least common, but those individuals who do have stiffness in the shoulder, in which case stretching may be useful for them to deal with less irritation to the shoulder, and the stretching might actually be pain relieving in those circumstances. As I was kind of alluding to in the last slide, too much emphasis is often placed on stretching early on. There's only one type of person that is going to benefit from stretching, and this is the least common scenario for someone who's injured their shoulder labrum. And then finally, impact training. I can't emphasize this phase enough. It is often what is overlooked in a lot of rehab programs. It's a forgotten and often poorly approached concept in rehab. Doing this properly with the proper volume, intensity, and exercises takes someone back from 80% to 100% back to full-on activity, sports, lifting, whatever it is they enjoy to do. So that needs to be part of your program. Now, when do you get to that point? Well, first it's understanding where your symptoms are currently at and where you need to go. So if your symptoms have a highly volatile range, then we need to lower that volatility down and get these pain levels under control at rest. So pain levels at rest need to be between 0 to 3. And if it's not between 0 to 3, then we have to start removing activities. So this might mean taking away some of the lifts that are aggravating. This might mean stop your sport or reducing your playing time to get the pain levels under control. That is the first step, and we have to take note of that side of the equation. I'm not somebody to tell somebody to stop doing something they love, but we need to get the pain levels under control. Once the pain level's under control, then we can start addressing it from a capacity standpoint, building more tissue tolerance so that you can start doing more and more things that you enjoy to do. How do we do this? We do it first and foremost through isometrics. So if you do have highly volatile pain symptoms, oftentimes the easiest thing to do to keep yourself active is isometrics. So I say isometrics for all, stretching for some, because again, stretching, while it may feel good in the moment, oftentimes later on causes pain and problems or increase in symptoms for someone dealing with a shoulder labrum injury. So we want to think about this from a load in a modified range concept before pushing depth and range of motion deeper into some of the exercises. And we'll get into examples of this very soon. And then finally, again, as I alluded to earlier, the final stage is going to be impact training. This is overlooked by many individuals and done poorly by rehab individuals. So being able to return to sport requires impact and plyometric progressions. They are a must. Understand that if you're training a muscle in a weightlifting scenario, muscle is going to respond to slow speeds, time under tension. But if we're looking at tendons, ligaments, and labrums, they're going to respond to faster speed, and we want stiffness on impact for those exercises. So we have to train that quality differently than what your normal strength training would look like. You have to prepare your body for both circumstances. So what does this start looking like in practice? Well, if I get someone with a shoulder labrum injury, oftentimes I'm starting them with isometrics 4 to 5 times per week until we start impact exercises, in which case their pain is likely much lower at that point in time, and we can start backing off the frequency of someone doing home exercises that involve isometrics. Your typical strength training, so concentric eccentrics or isotonics, think of rows or bench press or any sort of movement similar to that you might do in the weight room. We're just going to be doing those 3 times per week. And again, we need to be mindful of pain levels. So if the pain is increased than 0 to 3, there might be some of these strength training exercises that we have to remove for the time being and gradually work them back in as symptoms allow. Stretching 3 times per week, and it's only appropriate. Again, it's the least likely scenario, but again, you should be able to display your fullest range of motion that you do have available to you. So in stages, if we've been avoiding stretching for somebody for a long period of time, we might introduce stretching gradually as well too, to get their full range of motion back towards them. Again, this happens on a spectrum depending on the level of hypermobility that a person may have. There's oftentimes people who have a lot of hypermobility that I just tell them, if you feel the urge to stretch, then just think about stretching to move. Don't think about stretching to force yourself through a larger range of motion, because there are some people who don't actually need to stretch. And so when we talk about, do you need to stretch or do you not need to stretch, we need to put objective distances behind the sensation. I put sensation in quotes because that's all that tightness is. It's a sensation, and it's oftentimes misleading. Understand that gymnasts are going to still feel tight when they do the splits, but it doesn't mean that they're actually tight at all, because 90% of the world's population can't do a split. So the fact that they feel tight in a split position is just because they've reached their end range of what their muscle can go to. I can't do the splits, so I'm going to feel the sensation of tightness much sooner. So again, tightness or the sensation of tightness does not give you any info on the distance of motion. We have to put an objective distance behind the motion to determine if there really is true tightness. So if we look at a textbook, textbooks would tell you that these are the normal range of motions that you would consider. And realize for some sports, if you go beyond this range of motion, there is a risk-reward trade-off on performance versus injury risk. So just understand that if we're going to extreme circumstances. So flexion, getting the arm up overhead, 180 degrees. If I raise my arm up overhead, you should see that the arm is in line with the ear, or the arm is pointing straight vertical towards the ceiling. Extension, reaching behind the back. This varies in textbooks, so somewhere between the 40 to 60 degree mark, depending on what textbook you read. Rotation, so rotating the arm back and forth. We're looking at a total arc of 180 degrees. So there's a picture here on the left-hand side that shows 2 different scenarios, 2 different range of motion values for external rotation and internal rotation. But you can see that both scenarios, the total arc is 180 degrees, in which case we would say that this person does not have any tightness whatsoever from a rotation standpoint. They have her full 180 degree total arc, which is what we're looking for. Again, if this is a pitcher, maybe they have more range of motion. So in totality, again, somebody who's hypermobile, maybe they have more range of motion in totality, but just understand that there's risk-reward trade-offs in performance and injury risk potential. And then finally, just a note here at the bottom, if you're going through any of these range of motions and you feel apprehension, like the shoulder is going to dislocate on you, you've probably likely compromised the labrum to a degree that might need surgery. Not always necessary, but if you feel that, if you just move your arm a little bit and you have some apprehension that it's gonna, pop loose, that's not a good sign. You should probably get some more in-depth imaging if you haven't already, and this might be more of a surgical case. Versus if you have that range of motion with no apprehension, likely you're going to respond to exercises, and there's a good chance that you aren't going to need any surgery. Some other simple rules that are easier to test out on your own and still based on objective distance goals, not the sensation of tightness, is somebody's overhead reach. So can you stand with your back against the wall, take your arms up all the way overhead and hit your thumbs to the wall without arching your back? How easy is that for you, or how much substitution do you have in the low back? If it feels really easy, there's not much tightness at all, you're probably a little bit more on hypermobility side. You can then look down at a different joint, such as the elbow, have them extended all the way, and if there's a lot of hyperextension at that elbow, likely that theme is going to populate at other joints of the body as well too. So if it's at the elbow, likely you're probably a little more hypermobile at the shoulder as well. The scratch test down below here, the person on the right is someone who has stiffer shoulders. It's the same person who's just demonstrating it. But on the left-hand side of the picture is more kind of textbooky normal. The easier it is to touch your fingers together, like some people can clasp both hands together with that. That's again someone who has more hypermobility at the shoulders. So here are the different phases again. These are isometrics, exercises that I like to start off with. And then again, we progress towards isotonic or your standard strength and conditioning exercises. So realize that anything down by your side here, such as this picture with the band looped around the wrists, is going to be easier than up high here at the 90-90 position. But if we can tolerate this 90-90 position, we want to take advantage of that as well too and do isometrics there. But the easiest one is going to be here, just standing, pushing out into a thick band. You're really not moving your arms out very far. You're just pushing out into the band and holding 30 seconds at a minimum, upwards of a minute at maximum. If you can do 3 sets for longer than a minute, you probably need to up the resistance. If you can't get to a 30-second hold, you've gone too hard for the resistance. So we want to stay in that window. So shoulder external rotation, pushing out into the band. And then we have 90-90 position, which is a little bit more aggressive. So make sure your symptoms allow for you to do this, but you're pushing inward into the band, and then you're going to do the opposite, facing towards the band and push into external rotation again. So both directions, use a thick band because again, we don't want to see a ton of movement happening. What you can also do is I'll have people just purchase a toe strap off of Amazon for like $5, or just use a belt. And that's essentially an immovable object to rotate the arm in any direction as long as you attach it to a post, a beam, or something that sturdy that you have at home. Another exercise from an isometric standpoint, it's a little bit more dynamic, is out wide, just doing some arm circles here. Very simple exercise, but it adds a little bit more dynamic motion to it, just so it's not boring as heck, just holding your arm straight out to the side for a period of time. So you could go 30 seconds one way, 30 seconds the other way to get to a minute total, or 15 seconds one way, 15 seconds the other way to get to 30 seconds total. Again, staying between that 30-second to a minute range. If you can go longer than that, start adding some dumbbells in the hand. 2-pound dumbbells are going to be a great starting point for a lot of people. You're not going to get super heavy with this exercise simply because the duration of the exercise is so long. And then finally is laying on your side here, doing an abduction out to the side, kind of holding at 30 to 40 degrees. Again, you do not need to go heavy with this weight because again, the duration of the exercise is going to be between that 30 seconds to 1 minute. Just holding in that position, feeling right underneath the acromion. That's right where we want to feel the exercise here. It'll feel like your deltoid, but you're hitting a muscle much deeper than that called your supraspinatus, which is going to help support the labrum from a soft tissue standpoint. Moving on from here are more your typical exercises. So I've ordered them in the order that I try to introduce them to people. So once this motion here becomes comfortable for somebody doing isometrics, then I'm going to get them to do it isotonically, where they go through the range of motion. So I'm pulling down, I'm pulling back, and we do it in 3 positions. So it's at your side, right here, in and out. It's at 90-90 flexion, in, and then pulling out, and then it's 90-90 abduction, going in this direction. And I have videos of those too that you can have access to. And all of these are laid out on our workout program too, so you know when to do them, how many to do. We have it all laid out in our workout PDF that you can have a chance at purchasing. I'll talk more about that at the very end of today's lecture, or you can find that down in the link in the description below. But rows are oftentimes very commonly comfortable for people with a shoulder labrum issue, so you can oftentimes introduce that right away. Front raises, lateral raises, we're going to do those in 3 positions. So that's going to be the palm facing down, the thumb facing up, and then we're going to do it with the palm up. So again, very similar to these isometrics here, but now we're turning it into more of a strength training exercise where we're going through a full range of motion. I'll start people out to just 90, but then with the thumb up, at least I'll go above 90, both out to the side and in front of the body. So again, it's that concept of load through a modified range of motion first, and then start taking the body through its full range of motion as the pain and symptoms allow for it. Bench pressing, you'd be surprised. Most of the time, a pronated, so hands like this, palm facing towards the feet, is going to be more comfortable for the bench press versus a neutral grip bench press where your palms face towards one another. Neutral grip puts a little bit more tension on the bicep, especially in that bottom position, and that's why that is a little bit more uncomfortable for people. Oftentimes, to limit that extension or how far down the shoulder goes, we can put somebody on a flat bench and raise the incline up just slightly, so it doesn't have to be at full incline, but just slightly takes away how far down that elbow is going to drop behind the torso. And that takes a lot of the tension off the bicep tendon and the labrum. Again, same concept, taking you through more of a modified range of motion and then eventually through a full range of motion as the symptoms allow. Another strategy that people will often use is a floor press, where the floor stops the elbows from dropping behind the torso. But a lot of times setting up the floor press is more of a hassle, especially if you're doing this with dumbbells. So if you just go to a bench and you don't let the elbow drop behind your torso, you're going to be doing the exact same thing. Push-ups, I put that after bench press because you at least have to be able to bench press comfortably 25 to 30 pounds in both arms before you're going to likely feel comfortable with a push-up. So I start with bench press. Depending on somebody's symptoms, we do have to take away the weight quite significantly. And even for strong powerlifters, a very deceiving exercise is doing a bench press with a band wrapped around your wrist. So you're doing a neutral grip bench press, but you're pushing out into the band. And then with no weight, you're just simply laying on the bench on that slight incline and doing a bench press back and forth. That is very challenging for a lot of people. And so if we can't load a bench press up because the symptoms don't allow for it, that's how I'll start people with the bench press, is push out into a band and just go through the bench press motion, laying on your back. And then if you add just 10 pounds with that, for many people, 10 pounds with the band pushing out and going up and down, that's going to be very, very challenging for a good number of your patients. Certainly you could get heavier with that depending on how strong the person is, but likely if they start getting into 15, 20 pounds with the band, they don't need the band anymore to make it challenging. They can just start upping the weight at that point in time. Obviously, a chest fly, we're really reaching out into that stretch position, is going to be a little bit more agitating than a typical bench press. Again, it takes the concept of stretching becoming the last thing that we would go back towards. I like the concept of taking resistance through a stretch position, because you're going to always err on the side of less range of motion when you do it with a weight, versus if you're just forcing yourself into a stretch, you can jam yourself into a pretty large amount of range of motion. And again, if the labrum doesn't have its full capacity built back up again, oftentimes that becomes sensitive for people. So taking a little bit more of a loaded stretch approach oftentimes helps people err on the side of caution. And then further down, we have overhead press, overhead pressing, landmine pressing. That's usually a little bit more comfortable first. Hanging is actually deceivingly tricky to get back to sometimes for people with labrum issues, because it's that traction aspect of the shoulder hanging straight down. Again, that's one of the mechanisms of injury to the labrum, is a traction-based injury. And so hanging can oftentimes be a struggle for people to get back to, and we have to start really slow with that, which if you can't hang, likely you're not going to feel comfortable going through a full range of motion with a pull-up. Utilizing hanging or a scap pull-up is oftentimes an easier way to start for people in the beginning phases of trying to transition into doing a full pull-up. So a lot of times I'll start people there before transitioning or progressing to a full range of motion pull-up. Now, one postural concept to note, again, posture is a finicky thing. Sometimes it's useful, sometimes it's not useful when somebody is dealing with pain, but it is useful to test out to see if it is making a difference for somebody, and you shouldn't worry about coaching or cueing some different alignment with exercises. So one of the simple tests you can do as a clinician is to do this scapular repositioning drill when you raise the arm up overhead. What you would do is you just gently pull back on the shoulder blade and guide the shoulder blade upward rotation as the person raises their arm overhead. If that posterior tilt is helpful and they have less pain with raising their arm overhead, then giving somebody these cues to help out with alignment may be a useful thing to get them to perform exercises more comfortably. And what we're trying to do here with this is mitigate or at least delay the anterior migration of the humeral head in the socket, placing more pressure on the anterior structures of the shoulder, such as the bicep tendon. I'm bringing this up in the shoulder labrum section because, the shoulder labrum is part of the bicep tendon. So oftentimes this alignment or anterior humeral glide can be impactful for somebody with a shoulder labrum issue, which is why I'm bringing it up now versus other shoulder pathologies. Another way of looking at anterior shoulder migration is laying somebody supine on the table and just seeing how much the shoulder is elevated up off the table relative right side versus left side or just in general, the further that that's elevated, or if you look somebody in the side profile view and you see that the shoulder, the lateral aspect of the acromion is, out in front of their ear or out in front of their lateral hip, the greater trochanter, then you know that there's some just natural tendency to have an anterior migrated humeral head, which can place, again, a little bit more stress on the bicep tendon. So all that we're trying to do is delay some of that stress to the bicep tendon as someone experiences shoulder extension. Realize that it is normal mechanics for the humeral head to roll forward in the socket the further you take the elbow back. So in many circumstances, the easiest solution is just modify range of motion. You can see here if the elbow stops even with the torso, the alignment stays much better than if you drive further back into elbow extension. So the simplest solution is just modifying range of motion so that there's not as much stress to the anterior shoulder structure. And then eventually, as the shoulder gains more capability, then you start allowing them to go deeper into shoulder extension. But you can provide some cues to, again, delay that anterior migration just a little bit, which can make a difference in somebody's pain. So the cue that you would give is sternum up proud, collarbones proud and wide. What that does is, think about the cue of chest up proud, is that that will bring the eardrum and the acromion backwards or posteriorly just a little bit, and again, help with some of that glenohumeral congruency within the socket to place less stress into the anterior shoulder. Or think about that collarbone wide presentation. That's going to naturally draw the acromion just a little bit further backwards. You'll see other people cue this as bring your shoulder blades down and back. I don't like that cue, because if you apply that to every circumstance, such as raising your arm up overhead, the shoulder blade should not remain down and back. The shoulder blade should just move freely as you move your arms. So that's why I don't like giving a shoulder blade cue. I give a chest cue. So collarbones proud, chest up, or collarbone up proud. So wide and proud, those are the two cues that you'll give. Now, the mistake that people will make, or the substitution that people will make, is they'll just drive lumbar extension. So when you give the chest up proud cue, a lot of times they just hyperextend at their low back or the inferior aspect of the lower rib cage. And so sometimes you need to do drills to create some line of reference around how to do that, because many times that's what you see people do, is they'll just substitute shoulder flexion for lumbar extension. And that's not what we're trying to accomplish with that cue. So that's something just to be aware of when you start cueing it, that they're not driving hyperextension through the lower rib cage and the lumbar spine. Not that lumbar extension isn't bad, it's just not what we're going for with the cue. And the lifts that make the most sense for this is things such as rowing, dips. Dips are definitely an end stage exercise to do here because it needs a lot of shoulder extension. But bench pressing, all those cues, push-ups, they make a difference, because when you're in this shoulder extension position, again, if we can delay some of that anterior shoulder migration, again, chest proud, chest wide, that will oftentimes help people's symptoms. So the top position of the row, bottom position of the push-up, bottom position of a bench press, that's the cue that you're giving somebody. Now, the final step, as is with many of the issues that we've talked about, is returning to sport, gaining some plyometric and impact exercises. Now, generally we'll start these, again, as always, when resting pain levels are at 0 to 1 out of 10. And then when we're doing activity, the most pain that someone should have is a 3 out of 10, and there is no lingering pain with that activity. That is a sign that you can start some level of aggression to plyometrics or impact, even if that impact training is at a minimum. Now, the two exercises that I like the most here from an intensity standpoint to start at a minimum is the shoulder flexion and abduction catches. So it's a toss of a weight up, and then you're catching it or sticking it right at 90 degrees into shoulder flexion, and then doing the same thing out wide, tossing a weight up and catching it, sticking it at 90 degrees. And you can start with something simple as a 2-pound dumbbell or a 5-pound dumbbell for most people. And a lot of times, again, if they're at this sort of pain level, that will go well for somebody. Another super scalable impact exercise is a plyometric push-up. You could start somebody kneeling on the ground using a bench and just kind of catching themselves in the bottom position and then tossing themselves away. That oftentimes is very easy for many people to start off with, or even easier yet would be using a wall plyometric push-up, where you're just throwing yourself and catching yourself on a wall as you do a push-up. So these two exercises are scalable for a lot of people, but that doesn't mean like something internal and external rotation shocks aren't useful too, because you can grade the intensity of that to something like 50 to 60% effort. So with the internal external rotation shocks, we're always doing them in 3 positions, just like the rotator cuff exercises: at the side, 90 degrees of flexion and 90 degrees of abduction. If we look at this position here, this would be 90 degrees at the side, so both internal pushing in and external pushing out. 90 degrees of abduction, pulling down and pushing back, and then 90 degrees of flexion is with the elbow straight in front of you, pushing out and pushing in. Now, all of these exercises, again, can be done with a toe strap, and so that towing strap provides a jolt or a shock because it's an immovable object versus a resistance band or a cable machine give through the range of motion. We want that shock to create more tendon impact, tendon development, tendon resiliency that we're going for. We can also add some throwing exercises into this position, so using a wall and just throwing a ball against the wall and playing catch at 90 degrees of abduction. We can go overhead, we can do a backwards throw into the wall. If you don't have a wall, you can use bands in a squat rack just hooked up to the J hooks and go back and forth into the band very, very quickly, back and forth into a thick band, just like you saw us do with the hip labrum exercises for different muscles there using a band in a squat rack. You just have to set it up to the right height to do that for the shoulder. So anything you do for the shoulder or even the knee, that's what these drop catches and the push-ups are like, is just like a drop catch off of a box, where you jump off a box, you catch yourself in the landing for a patellar tendon development. You're doing the same thing for the shoulder. That's what the drop push-ups are, is you start on an elevated surface and then you basically fall down to the ground and catch yourself in that push-up position. Something like a 6-inch box is many times a great place to start with people, or doing something like a clapping push-up would be an end stage impact exercises for the push-up progression. The last one you see here is horizontal abduction shocks, just like what it sounds. We're doing horizontal abduction and adduction really too, with that toe strap to provide that shock or that impact out wide with that long lever arm position. All right, so you've made it this far. We're down to the end. If you found this video useful, be sure to like and subscribe to the channel. We want to get this information out to as many people as we possibly can to help as many people out. What you can do to help us would be to comment down below. Comment anything. Drop a fist pound if you found it useful. That just drives this video out to more people, so more people who are dealing with shoulder issues can find this and find help from it. If you have a question, feel free to drop that down into the comments section down below, or if you have suggestions for future topics as well too, those are other things you can drop in the comment section. Comments are very useful to drive this channel further along, so again, it can help more people out, and we appreciate you doing that. We don't take it lightly, and we want to provide you the best information that we can possible. If you're a rehab clinician or strength coach and you're looking to combine these rehab strength plyometric concepts to make more durable athletes and human beings, to move your career forward, we have a course, continuing education course for you. You can find that at sportsrehabexpert.com. It's called the Sports Rehab Expert Certification. If you're watching this and you're dealing with shoulder pain and you want my help directly, a couple ways we can help you out. You can visit us at sportsrehabexpert.com, and we have a downloadable PDF program that you can pay for that walks you through all the different phases, all the sets and reps, all the different exercises, and can help you overcome any shoulder pain issue and get you back into playing any sport, lifting that you want to do. Or if you've been dealing with this issue for a while, maybe there's more re-injuries that have occurred, there's more things going on, you just need a little bit more direct one-on-one help. We can provide that through custom programs or in-person session through Zoom to provide you with a more personalized approach. And if you need access to that, you can email me, Greg at sportsrehabexpert.com. I'll give you access to my schedule. We'll set something up. That obviously is a higher price point than what the PDF would be. If you are local to the Ann Arbor, Michigan area, you can always visit us in person as well too. And you can find my in-person website at annarbor.physio. So whether you're in person or working with us together online or through the PDF option, we look forward to giving you the best help possible. Thanks again for watching this video, and stay tuned for future videos that we put out.